afternoon. I am Dr Prashant Joshi, Consultant Reproductive Medicine, Milann Fertility Centre, Indiranagar, Bangalore. Nice to be on Facebook Live. Today I am going to talk about an important topic, Azoospermia. Azoospermia means zero sperm or nil sperm count in the ejaculate. This condition is quite very common. Previously the incidence used to be a little less, 0.5%. Nowadays the incidence is increasing. The current incidence is around 1% of all the male population. Example is, yesterday all of you had watched the cricket match India and Pakistan, and it was really terrible for India. And around suppose 40,000 people are there in the stadium and 20,000 of them happen to be males, then 200 of them are azoospermia. So that's how common it is. And especially when you take the infertile subpopulation of men, around 15 to 20% of these men are having azoospermia. So this is quite a common condition, but still we don't talk about it. Guys we are brought up that way actually. We can't speak over chai pe charcha to some friend of mine saying about this condition, or even with family members. And when the report comes, lot of guilt, feeling that I am responsible for her not becoming a parent. All these feelings come in, and it hurts the ego, male ego somewhere. And also there is a lot of despair. People lose hope. They think whether I can become or no a biological father. All these questions, doubts, anxiety, our energy levels go down, anxiety, sleep levels go down, quality of life gets affected. But good news is majority of these guys can easily become biological fathers. So it is not like in 1990s when person had to go for a donor sperm. So today donor sperm is the option set. Majority of these men can become biological fathers. But before that, let us see how this azoospermia is diagnosed. This test we do for diagnosing azoospermia is a simple semen test. Semen analysis, what we say. But you have to do the semen analysis test in a standard lab which is probably attached to an IVF center, because that says that the lab is standard. Otherwise what happens is generally a person meets a physician or a family physician and he writes some test for infertility, and you do it in a lab which is not handling that many of semen samples. They might be doing 1 or 2 in a week or sometimes in a month. So many important data are missing, like the volume, the pH, whether fructose is present or absent. These finer things also give us a clue, and most of the times these important data are missing and we have to repeat when you come to us. So it is important to always do semen sample in a standardized lab, and 2 semen samples tested at least 1 month apart is good to make a diagnosis of azoospermia, because there are biological variations. In the one sample you might have 0, and second you might get some sperms actually. And also the labs need to centrifuge, spin the sample and search for any hidden sperms, because so many cases of cryptozoospermia also I have seen, where they are hidden in the palate. If you take, there are some hidden sperms, and this condition is called as cryptozoospermia. So that is about the how you diagnose about azoospermia. So let us see why this azoospermia happens. There are 2 main reasons. One is called obstructive azoospermia, that there is some problem in the passages. As you all know, sperm is produced in the testis, which I call as the factory, and from the factory it has to go to the go down. So there is a passage in between, and the go down is the seminal vesicle, and from there it comes out to the external world. So somewhere there is a passage problem. Either vasectomy they have undergone, or nature itself has done a vasectomy in form of scarring and blocking the tube. Might be due to a childhood infection, tuberculosis, any epididymitis, any inflammation which has caused scarring and blocking of the vas deferens. And the good thing about this obstructive azoospermia is you can retrieve the sperms very easily. 100% chance is that, because this is due to an obstruction. Sperms are being produced. So we have our job is just to get these sperms and achieve pregnancy. That is about obstructive. Then we come to the other cause, that is the factory problem, that is testicular problem. In this again we can divide as purely problem is in the testis or it is higher up. Sometimes hormonal problems. I say as electricity to the factory. For the factory to produce, you need electricity. And this electricity is in the form of hormones. Around half of these non-obstructive azoospermia patients have some hormonal problems. So if we correct these hormonal problems, there is a good chance that they can also achieve easily pregnancy. So that is hormonal. Then there can be sometimes varicose veins which raise the temperature, some toxins are not drained, and this can also lead to azoospermia. Of course, we have to check the genetics. Is there some problem in the karyotype, Klinefelter syndrome, or Y chromosome microdeletion? Y chromosome microdeletion you should check whether there is any of these three, azoospermia A, B and C, the regions in the Y chromosomes, A, B and C, where in A and B you don't have sperm production, whereas in C you get a good number of sperms, but then if you have a male child with azoospermia factor C, then the inheritance of this azoospermia can be there. So all this genetic counseling has to be done. In rare cases you can have bilateral vas deferens absent, that is called as CFTR analysis, cystic fibrosis recessive gene. All this genetic testing might be required in these cases where a genetic cause you are suspecting. So all these are the causes for, very rarely even you can have some cricket ball injury, the trauma to the testis, and that's why the sperm is not being produced, or some mumps orchitis in the childhood, or they have taken chemotherapy and gonadotoxic it has become now. These ideally I would advise you should freeze your semen before you go in for any chemotherapy. Semen freezing is a facility which many men don't know, and if you are having a cancer, anything which is going to cause you problem in the future, you can do semen freezing for these kind of patients. But in case they are azoospermic, still we have options for them too. And how to investigate, how to do the investigations for these patients. The first investigation is take a proper history, examine, check for the size of volume of the testis. Then I would do a hormonal test. Hormonals at the level of pituitary and the hypothalamus, check the levels of FSH, follicular stimulating hormone, luteinizing hormone. I would check the levels of hormones from the testis, how much testosterone is produced. Is there any low testosterone levels? Would also like to check the female hormone, estrogen, as sometimes it is elevated in men and impairs the production of sperms. And for these kind of patients, I would like to use aromatase inhibitors like anastrozole and letrozole, which convert this estrogen and testosterone. Especially we check the low testosterone estrogen ratio, and low testosterone estrogen ratio, that is less than 10, we need to start these medicines. Regarding the treatment, as I also said earlier, vast majority of them can actually become easily fathers. IVF is there, and ICSI. ICSI is a wonderful revolutionary process in the treatment of azoospermic also, because here you need a single sperm, which we can take a single good sperm, hold it with a micropipette, inject it into the egg and achieve fertilization. So even if we get a single sperm, good sperm, we can achieve fertilization. So our aim is to get the single sperm. In obstructive azoospermia, I told you 100% chance, we just need to bypass the block. Either we have to do a bacil reversal, anastomosis, or we have to microtap, put a fine needle and take it out the sperms from either the epididymis or the testis. This procedure is called as PISA, percutaneous epididymal sperm aspiration, or testicular sperm aspiration. As simple as that. You take and send it to the lab, you will check for the sperms, and most of the times you will get 100% in these patients, and so there is no tension, no headache in these patients. The next is non-obstructive azoospermia, and I already told you hormone problem is the most common. 50% of them have hormone problems, and we can easily set it right. Just like how you give injections for getting the follicles to right size, you might have to give injections for these patients up to 4 months. And again, just by giving injection, 1 out of these 10 people will produce sperms in their ejaculate. So they don't need to undergo any surgery. Even a small surgery like a micro tapping is not required. Even a PISA is not required in these cases. That lucky one. But the remaining, there is production in the testis. It might not be so much that comes out in the ejaculate, but there will be patchy production. In these cases, a wonderful new revolutionary technique called as micro-TISA. What is this micro-TISA? This was till 1999 not there. 1999, Mr. Peter Schelger from New Cornell University of US, New York, he thought, let me bring the microscope to the testis and see if any patchy production is there, and differentiate whether some tubules are producing, some are not producing. Can I differentiate? And when he took the microscope and saw, he could easily differentiate. Those seminiferous tubules which are producing sperms were fat, and they had the sperms, and those which were not having sperms, they were thin and they were flabby. So this way, even minimal tissue he could choose, select, pick and choose, and get sperms with minimal amount of tissue, minimal amount of testicular damage also. So the testosterone level after micro-TISA also does not drop dramatically, and even it drops slightly, and at the end of 2 years it's normal testosterone production. So that is the advantage, and that is the revolution with micro-TISA. And with micro-TISA, 7 out of 10 men can get sperms. So that is what I said. Vast majority of the patients can easily become fathers. And ICSI, micro-TISA and other sperm retrieval techniques have changed the name of the game. In 1990s, yeah, if Vicky Donor film had come and people saw it, I would have said yes, this is the right film for the right generation. Of course, I like the film, and it has changed attitude of people towards donor gametes. But I think the importance of donor gametes is reducing in the present day scenario. When we can achieve pregnancy through self and give him a self-biological child, then I think that is the most wonderful news for a medical infertility specialist of these days and the patient per se. So with this, I would like to share one success story especially, which I thought I'll tell, which might act as motivational for a lot of people. Like I had this person who was in a big post, I can't tell names for sure, but this guy had been diagnosed with Azoospermia. It was a very difficult thing for him to take, and he had almost cut out all his friends, even in social media, those who had kids. So that was his state. He was very, like, when he came, he was very reluctant to even talk to his wife, forced him to bring and all that. And when I did the hormonal test, I found he had hypogonadotropic hypogonadism. Put him on hormones for 4 months, and he was the lucky one who could get sperms in his ejaculate. And he didn't have to undergo any surgery, and his wife underwent IVF, and she is conceived with 2 babies, and they came. And now I told him, first thing, you get your friends back, and you need a social life, and you can't just live like that. And he said, sir, once she became all my friends, I had a big party. That is how his life has changed. The energy levels change, because when you have positive things in your life, you are stress free. Your energy level, even with hormones, when they are deficient, sometimes the energy levels drops down. But yeah, not all azoospermic patients, they will have low energy levels. Many of them, it's a shock when they get the result, because they are telling he is very active, sexually very active, he does all the work, white color fluid is producing, but when you give the test, you come to know it is azoospermia. So male should not think like only the female is responsible for the problem. In 40-50% of the cases, males are the problem. There is a milder form called OATS, where there is oligoasthenia, teratospermia, but the more severe form, azoospermia, is also there. But the good thing is, for all this, there is a treatment in the present day generation. And this is a topic very close to my heart, because male fertility, because the males are more comfortable telling this problem to us, even for examination and all that. So, and the best part is it can be treated. That is what gives the job satisfaction. You can treat it easily. And so, subject close to my heart, so I thought I'll do a Facebook Live on this topic. And if any of you are having this problem, don't suffer in silence. Meet your fertility expert who is having experience in this field. And we at Milann do 100% from A to Z all treatment for this condition. So it is a nice interactive session. Any questions from anyone? Yeah, the common things are like, 2 to 3 days of abstinence is required when you're doing a semen analysis, and do it in the best lab, whichever is the best. 15 million is the normal sperm count to achieve normal pregnancy. Patients who have got sperm retrieval, they can't impregnate naturally. All of them will require IVF and ICSI. ICSI is where we choose a single sperm, okay, and we inject it into the egg and to get a good embryo. The aim is to get a good embryo, because if the seed is good, then the pregnancy is good. Any other questions? You can even contact us if anything. Thank you. Keep following, keep liking our videos. Have a great day. Thank you.
This